Good afternoon. Let's see how we're going here. All right. So one of the things I want us to think about is why do women have poorer outcomes than men? What are the underlying causes? What will it take to close the gaps? We know that women have more undiagnosed cardiovascular disease. They have worse trajectories, and they die at higher rates than you would expect. If you look at the Health United States, for years it has said, well, that's because women are older. And it's kind of ignored that we know that it's also because of differences in presentation. Because women are less likely to get referred to a cardiologist, because women are less likely to get sent to rehab or to complete rehab. So we have a lot of different things playing into it other than women are older. So I came into this work in part because I knew when I was in college I wanted to do work that would make a difference. I wanted to do work that would have an impact on health and health care. And I believed that if we did good research, we would be able to have better policy, both capital P policy and the legal regulation kind of side, and guidelines and practices on the clinical side and the routine aspects. I found out in graduate school that most research doesn't do that. It doesn't end up informing policy. But I've been lucky to get involved with people both in the Right Care Initiative and in other settings that are doing work that's aimed at making a difference. Now, in my current work, my colleagues and I are mapping gender differences in routine aspects of cardiovascular care, both the care for patients with established cardiovascular disease and patients with diabetes. Now, unlike other areas of healthcare, where women, if you say get screened, they get screened. If you say get treated, they get treated. And because women are often more compliant, they often have better outcomes than men. When you look at routine aspects of care, and here I'm thinking of HEDIS measures, but routine aspects of treatment among patients who already have established cardiovascular disease or diabetes, we see gaps of 5-10 percentage points, higher quality of care for men than women. The only other area, when you look across medicine, that you see that kind of gap is in HIV/AIDS care. So these are two areas where we have this lingering view of a disease as a specific to men. Now, nobody set out to design the screening and treatment for cardiovascular disease not to serve women. We set out to understand a problem where we had men presenting with clear presentations and where we had studies based on animals where we got results that made sense with men and we got different results with women. And I would argue a little bit with Carol as to whether that was a real sound scientific thinking. It was certainly sound to say, well, we know what's going on over here, let's study it. But there is, in fact, a big problem if you say, well, we're getting different results in the females, so let's not do any studies in them. But we can probably still generalize from males, not only from male mice, the white male mice to the white male people, but then we can generalize over to the female people too. It hasn't worked well. Well, you might think that part of the reason that we have differences in outcomes and so on, differences in quality scores around heart disease, is because women present differently. But that can't explain what's happening among people who already have a diagnosis. It could be because our screening tools don't do quite as well, but that would mean we're missing some of the people. It wouldn't explain why we're doing more poorly. But we do know the differences in that men are more likely to have major coronary artery blockage. They're more likely to be identified in our standard approaches of testing. Women are more likely, as it turns out, to have microvascular disease, to have blockages in the small vessels of the heart, to have forms of ischemic heart disease that are harder to capture in the testing. And that's above and beyond the kind of gaps we're looking at. The other piece, and we saw some graphs earlier today of the 1990s and the gains that were made in men's survival of cardiovascular disease. And those were made in large part because of the success in treating with statins. Now, he stopped with the figures at 1999. If you go on up through the 2000s, you finally start to see where we were doing better with statins with women, and we start to close the gap. But we still have these large gaps. Now, this matters because we have this focus, this machine built around understanding and treating breast cancer. that women buy into. We have the whole Pinktober month. In fact, it's the amount of funding that goes to research on breast cancer. It's the lion's share of all cancer research. Even though about the same number of women die of stroke as die of breast cancer, we have more money going to breast cancer research, 3 times more than all of the cardiovascular disease research. Within the cardiovascular disease research, we do now include women. Sometimes as much as 20% of the sample, but in only about 28% of the cases do they even describe the sample by sex. Only in about a third of those cases are any subgroup analyses reported. So we often don't actually know whether the findings held for the women in the study. And if we have differences, and as we've just begun to start looking at those differences across a number of studies, if we have differences, a bimodal distribution, then it means not only are we misunderstanding how to treat the women, but we're also missing how to optimally treat men because we put in 2 groups of people that are responding differently. And in fact, we're trying to treat an average person that's somewhere in between that doesn't even exist. So there are a lot of reasons we need to be able to do better on this. But even on the routine aspects of care, we want to be able to understand what's going on. So we started with where there's an area of agreement of cholesterol screening, treatment, and control. What's happening in terms of care. And the slides I'm going to show are just about screening of patients who had established cardiovascular disease. We worked with a health plan from California. Here we're showing it. We want to make the data accessible to everybody. So instead of showing a bunch of tables, we graphed the quality of care. This is called red light, green light graphing. Darker colors mean that you've got higher quality of care, and we use the same scale for men and women, so you can see easily. Now we can use the eyeball test instead of having to all know statistics, and see what's going on. And then to the right, we mapped the gender differences. And you see that in 7 out of the 8 areas that get used to look at quality of care, men were getting higher quality of care than women. And in 3 of those, it was actually between 5 and 10 percentage points better care in terms of just being brought back in for that routine cholesterol screening. And if you weren't getting screened, usually we're not getting treated for high cholesterol. We did the same thing looking at the patients with diabetes. Here now, instead of seeing on average across the state a 5 percentage point gap, we only saw a 2 percentage point gap, which sounds like it's a lot better. And it is an indication, because we don't have the same bias around diabetes, that we could be doing better, because there's no reason you would have a difference in the way we're treating. But there's so many more patients who already have diabetes that you actually have more women not getting indicated care in an area where we have clinical agreement about screening and treatment, where we have agreements around cost effectiveness. So this actually ends up mattering considerably. Now, we also wanted to say, how could we use this kind of data? How can we look at things locally enough that you could make a difference? So here we took it down to a county level. The areas are white where we don't have enough data. And that's not a problem of missing data. That's actually where there are fewer people living. And so we didn't try to compute gaps where there are fewer cases. And we're just looking at the gender differences in the care among the patients with cardiovascular disease and among the patients with diabetes. Now, in this coding, it goes from dark red, a gap of 10 percentage points or more favoring men, to dark blue, a gap of 10 percentage or more favoring women, which, as I said, you would see a lot of in anything other than cardiovascular disease or HIV. Among the patients with diabetes, you see a little bit more of that valence of that end of the distribution. And of course, since you're all from California, you probably also realize that most of those are less populated areas. Now, we want to take one other step. One of the other questions that we get asked is, well, is this happening in one particular socioeconomic group? Another question that we get asked is, well, do we have any idea what we would do about it? Well, we do know what to do about it. We can raise the quality of care. So we divided the data, and this is just looking at Los Angeles because we're looking at data from one health plan. So in LA, we could go all the way down to the census tract level. And we looked at separating the HMO and the PPO patients within this one health plan. And as most of you probably know, how HMOs tend to do better on routine aspects of care. They hit the mark more frequently on HEDIS scores, in part because they have those systems for getting it done. It's part of the whole MO, the whole idea behind an HMO is that you're going to work very hard to hit these cost-effective routine aspects of care, and it works. So they in general score higher on quality of care, but in addition, on average, we didn't see gender gaps within the HMO population. In contrast, in the PPO population, the care's not quite as good on the routine aspects, and women did worse than men. And if you know LA at all, if you know LA at all, what you're looking at down here, this is like going down to Palos Verde and so on. These are high SES areas. What's missing here is South Central LA. But these are high income areas where men are getting remarkably better care than women. Now, I presented this work at the three university best practices groups, and the San Diego group was incredibly intrigued. It's actually what led to us talking about this at the other groups. And they wanted to know, well, do we have this problem? They were intrigued because it's really seeing this gender gap it's a missed opportunity to improve care. And so they went back and they looked plan by plan at their own data and shared it fairly anonymously with each other. So the data group pulled it together. And they all found that they had gender differences in LDL control. And these are fantastic places. This is where you would want to be going to get your care. That work was received a lot of attention, and another health plan came back to us and said, we want to look across in different parts of the country and see what's happening in terms of our care. And so here we're looking at the diabetes population. If you remember, that's where we had a smaller gender difference on average in California. And what was happening in terms of control for achieving LDL control across 4 metropolitan areas. And so up to the top left, we've got Atlanta, and they don't really have any variability. This is all a 5 to 10 percentage point gap. To the right, we have Houston, most of which has the 5 percentage point gap. The rest had a 2 to 5 percentage point gap, still favoring men. Down to the right, we have New York. This is kind of a New York, northern New Jersey, all the way out Long Island and everything. And you see a lot more variability in New York, including some of these areas with very large gaps favoring men. And then at the bottom, South Central here. So this is Southern California. And an inset of LA, and you start to see there's a lot of variability going on even in the care. Now, one of the benefits of mapping is it's much easier for people to read. Another benefit is it puts it at the feet of people. They can look at it. Women know where they live. Providers know where they're providing care. So they start to get information that is in fact more useful than was happening with just giving a generalized report. One other place that we're applying this work, and we haven't gotten to mapping yet, but RAND does a lot of work with CMS using the 100% Medicare sample. So we've been doing a lot of work on racial disparities in the HEDIS scores. We looked across all of the HEDIS scores that we have. There are about 36 of them that we had data on everybody. And we looked at, this is the 6 that had a gender difference of 5 percentage points or more. And what you see is you've got a mental illness one at the top, one on potentially harmful drug interactions for elderly patients with dementia, women being more likely to get diabetes eye exams is classic. Women will go in and get the routine aspects of care handled, women being more likely to have glaucoma screening, and follow-up for hospitalization for mental illness. It's just in achieving control over LDL-C, over a calculated LDL. This was among the cardiovascular patients that we saw a gap favoring men.
So, Chloe, just to put a little fine point on that, when you see it's only for controlling cholesterol for the disease that kills most women,
It's the leading cause of death.
really large numbers.
If we're talking about really large numbers, we're talking about as you move into older ages, it being much more life-threatening, much more likely to end up being the cause of death. But it it's a big enough problem that I've decided to spend a lot of my time focusing on it, because if we can't do a better job on the leading cause of death for women, when it is the overwhelm, it's the elephant in the room, then we're really missing the boat. And it's not that I was new to studying this. I'd done work first coming out of grad school on women's representation in clinical research, and I did some of that for the Institute of Medicine and other things. When I first came to RAND in 2000, Alan Fremont and I, full disclosure, Alan and I are married. Alan Fremont and I, but we met in graduate school, I'm sorry. Yeah. So we did work. He had a project for ARC looking at gender, racial, and socioeconomic disparities in quality of care for cardiovascular disease and diabetes. And I think other than our program officer, Arlene Bierman, who was very interested in gender differences, the rest of the people were interested in including it just because they thought it would be controlling for the fact that women get better care for everything. But in fact, we found that women didn't get as good care as men on some of the blood pressure measures, on some of the control measures, both among the patients with diabetes and cardiovascular disease, and especially around cholesterol control. So we did, the regular academic thing. We looked at the problem across multiple states using high-quality data, found the average gender gaps, reported it in articles in the journal Women's Health Issues. There was enough interest from the American Heart Association and the National Center for Quality Assurance that they did a congressional briefing, so I was part of a congressional briefing on this in 2008, and that to me seemed like really stepping out there to make a difference. But it was so implausible that we were missing getting women in for routine aspects of care because women utilize health care. That even though we put that information out there, what plans heard was what my grandmother would say people heard in church. Those other people ought to hear this. Those other people. Yeah, it couldn't be a problem in our plan. It couldn't be a problem where we are. There's somebody else not getting it right. So it didn't put the problem at anybody's feet. And this is often the difference between doing research that's actionable and doing research that is an academic gotcha paper that gets headlines. So one of the issues is, how do we do work that engages policymakers? How do we engage the decision makers who have the stacks of papers, have all of the material they need to engage with? Well, what I tell my grad students now is that, to paraphrase Tip O'Neill, because you're old enough to know who Tip O'Neill was, even if they aren't, all policy is local. At the end of the day, what matters, whether you're talking to clinicians, to the directors of the provider group, to the heads of the health plans, is this one on my watch? Is this relevant to me? And ultimately, it ends to be the same issue for women, for patients. It's the reason why, in the discussions we had earlier today, that it's relevant to be able to give somebody a personalized risk estimate so that they know that there's something tailored to them and relevant, worth dealing with. Well, we need to have something that's accessible and has an impact, that they know is relevant to the care that is in their area of purview. Now, one of the things that we built on in doing this work is work that Alan's led at RAND, QDART, the quality assessment group, takes mapping into healthcare. Now, everybody here probably knows the stories of John Snow and the pump handle and the epidemiological work using maps. Kind of surprisingly, mapping has not been used in many other areas other than epidemiology. We use it to find hotspots of disease incidence. We haven't used it as much in other areas. However, he and his group have been using it for some time to look at racial, ethnic, and socioeconomic disparities in care, because where we live in this country is patterned by race, ethnicity, and SES, because you buy a home where you can live. It's not that there are total barriers to where you could live, but we have relatively segregated kinds of neighborhoods in many ways. We never used it to look at gender differences because we tend to live the same places, which I tend to think is a good thing. But I realized, as I got very frustrated with how are we having more success in dealing with identifying the racial ethnic gaps? Even though the health plan data doesn't collect the data on race ethnicity, we had to come up with an algorithm to interpolate the data to add it on to describe the problems. That was getting more success than looking at gender differences in the leading cause of death. And I thought, okay, it's time to start mapping. It's time to start saying, here's where the problem is. This is what it looks like. And to try to engage in some of the insight into the variability in care, and to start to see, as we saw with the California map, we're good, that some places we're doing really well, that not everybody has the same problem. And ideally, this starts to, and what we're seeing is it's working, it starts to engage people in saying, wait a minute, there's a return on investment here. If we're missing the women, there's something really wrong here, because we know women will come in and get care. So we brought the mapping to the problem in order to try to start targeting the interventions better, to start improving quality of care for women, improving recognition of who's missing in care. And as we do that, we also can see in the other aspects of disease where we're missing the men and where men aren't getting as good care. So it's not just about finding this gap, but there are also many areas where we can work more to get men into care. So we're not focusing on that gotcha approach. We're really trying to go beyond the typical tip of the iceberg, to look at where there's clinical agreement, and to push that we improve the answers we're getting from science, that we require the gender-based analysis, that we know whether or not the findings hold for women as they do for men, because that informs clinical decision-making. That feeds into whether or not clinicians think of women as cardiovascular patients. And we know they're not very good at thinking of particularly younger women as likely to be cardiovascular patients. We know we see lower quality of care, especially in the younger women with cardiovascular disease. And in the other piece of work we're doing with the multi-state data now, one of the things we found was when their data analytics team brought all of their measures in of who gets screened, all the algorithms to get people into care and get flagged for targeted programs. Even those algorithms unintentionally were incorporating bias, and younger women were not getting caught into the system. So we need to improve the science, we need to improve the expectations of the clinicians, and arguably we need to improve women's understanding and expectations, because while I agree with Carol that ultimately we have to change the conversation that happens one-on-one in doctor-patient offices, we will not get this done by trying to have lengthy one-on-one conversations that are millions of them to get women into the right kind of care. Women need to be able to go in better understanding that they need better secondary prevention, how it works, and they need to go into prevention in a better way. So thank you very much.